Thank you, David. It's good to be with you. I want to emphasize one aspect as we move forward of thinking of the large gaps in health by race, ethnicity, and socioeconomic status in the United States. In the interest of time, I will emphasize more race and ethnicity, but I think you'd see both of them go together. The next slide indicates that there are striking racial disparities in health, and the next slide gives some examples of the disparities. They cut across a broad range of conditions. They are most marked for African Americans and American Indians, who have higher age-specific mortality than whites from birth through the retirement years. Latinos don't do as dramatically negatively as African Americans and American Indians, but I think when we look at Latinos overall, we are missing some important heterogeneity within the Latino population. There are several recent studies that show that if you look at US-born Latinos, their health profile looks just like African Americans, and foreign-born Latinos' health profile looks like whites. And when you combine the whole population, you miss the divergence that takes place with increasing length of stay and generational status in the United States. Immigrants of all racial ethnic groups have worse health than their native-born counterparts. And one of the things that happens is that with increasing length of stay, the health of immigrants declines. There are large gaps in health, and we have not had a lot of success in narrowing them. The next slide gives examples of life expectancy from 1950 to 2006. There's good news and bad news in the data. The good news is that the life expectancy gap today, let's go back to the next slide, is narrower than it was in 1950. On the one hand, we've moved from an 8-year gap to a 5-year gap, so that's progress. But stop and think of what a 5-year gap means. If you look at where life expectancy has improved in the last, since 1980, it's an average of 0.2 of a year every year. So if we froze the life expectancy of whites, and African American life expectancy increased at a rate that overall life expectancy has been increasing, that's a 25-year gap between blacks and whites in health. Another way to look at the data is look at the life expectancy of whites in 1950, and let's ask how long did it take for African Americans to catch up to where life expectancy of whites were in 1950, and you could see a 40-year gap. It wasn't until 1990, so there's a 40-year gap in health of two populations living in the same society. The next slide shows data for the Indian Health Service. 60% of American Indians served by the Indian Health Service. It started in 1955 using one health outcome, diabetes mortality, but that same pattern exists for multiple others where the gaps today in the most recent data are larger than they were at the start of the Indian Health Service. Next slide emphasizes that if we just even look at life expectancy and overall mortality, we miss some of the striking patterns that exist because minorities get sick at younger ages, have more severe illness, and die sooner than whites. I want to give you 3 quick examples of that. The next slide illustrates breast cancer. Breast cancer is one of the few cases where the incidence rate of breast cancer is higher for white women than for African American women. But under age 40, the opposite is true. Under age 40, African American women have a higher incidence of breast cancer, reflecting the fact that at younger ages, this disease is so much more common in African Americans. Another example from in the area of cardiovascular disease, a study from the Cardia study, a cohort that has been followed from age 18 through 20 at baseline, now for 25 years. Incident heart failure before the age of 50 was 20 times more common in blacks than whites in the Cardia cohort. And one other example, an old example, but it really makes the point very, very dramatically. It goes back to Arlene Geronimus' study, looking at all first births in the United States for a given year, and looking at the variations by age in neonatal mortality, so a bad outcome, by mother's age. And we all think that it's good biologically. We also think it's good socially for women to delay childbearing from their teen years to their 20s, that outcomes would be better both socially and health-wise. What this data show is what we think is true for whites and for Mexican Americans. The opposite pattern is true for African Americans and for Puerto Ricans, where delaying childbirth, first childbirth, from the teens to the 20s are linked to worse outcomes. How do we make sense of that? Arlene Geronimus's explanation is weathering. Chronological age not only captures how long you've lived. If you live in a bad environment, it's also capturing how long you've been exposed to negative conditions and how physiologically compromised you are. And there's other work from Arlene and her team that documents this for a much broader range of outcomes. This dramatically earlier onset of aging, looking at allostatic load as a multiple marker of physiological dysregulation across multiple systems. She shows there's a 10-year gap in the health of blacks and whites in the United States, that the health that blacks have at age 40, whites have it at age 50. Next slide. We think that a big driver of the racial differences in health are, in fact, racial differences in socioeconomic status. We now know that it's more complicated than that. Next slide. So let's look at life expectancy at age 25 for the United States by race. There's a 5-year gap in life expectancy. Next slide shows us the variations by socioeconomic status within whites. And we see something that's a really important take-home message here, that the gap between whites of low education and whites of high education is 6.4 years, larger than the black-white gap. And that general pattern is found for most indicators of health status that many people don't realize. The socioeconomic status differences within each race are larger than the racial gap. It's an interesting sociology of knowledge question why we only tend to focus on race and not pay attention to the complex patterns that emerge by race and socioeconomic status. So you can see the same is true within whites, a bigger gap. However, next slide. Go back one, please. Yes. This really shows us the complexity of the challenge we have to deal with and we have to confront. Because there are factors linked to socioeconomic status that are producing these large gaps in health for both groups. But at every level of socioeconomic status, it's also true for income data. I'm not going to show you the income data. You see the persistence of a race effect. So white high school dropouts still live 3.1 years longer at age 25 than black high school dropouts, and that gap widens as education increases. So there are factors linked to socioeconomic status we need to think about, but there are also factors linked to race over and above socioeconomic status that we need to think about to make sense of this. And just to illustrate, this is not a fluke with life expectancy data. Let's go a couple other windows on it. Here's infant mortality among women aged 20 and over in the United States by mother's education. We see the power of socioeconomic status. As mother's education increases, infant mortality declines. That's true across racial ethnic populations. So the best of African American women, black women with a college degree or more education, they have the lowest rates of infant mortality among black women, but they have rates of infant mortality almost 3 times higher than other women with college education. And we find a striking pattern that these most advantaged black women are still doing more poorly than women of all other racial ethnic groups except American Indians who have not finished high school. How on earth do we make sense of this pattern, and how do we understand this additional risk profile that is linked to race producing these outcomes? Next slide gives another example. A study looking at exquisitely adjusting on social class by looking at 2 cohorts of physicians, an all-black cohort of physicians graduating from Meharry Medical School, an all-white cohort of physicians graduating from Johns Hopkins. They are all medical doctors in the United States, trained about the same time, working in the same profession. Their health should, in fact, be very similar. But no, we find the black doctors have a higher rate of cardiovascular disease, earlier onset of disease, incidence rates of diabetes and hypertension twice as high, higher incidence of coronary artery disease, and very dramatically, higher case fatality. Once they get sick, much more likely to have a bad outcome. Next slide. How do we make sense of these differences, and what else could it be about race that drives these? There are 3 factors. All of them play some role. We need to think of the life course. We need to think of the fact that all of our indicators of socioeconomic status are not equivalent. We need to think about racism. Next slide. Just one illustration of the life course. A study my group did using the MIDAS data, looking at early childhood adversity, one type of stressful life experience, and linking it to 5 markers of adult inflammation, and find a significant interaction for race that early childhood adversity, stress in childhood, predicts levels of inflammation among persons aged 35 to 90. So distal events having long-term negative consequences. Next slide. Examples of research on the non-equivalence of socioeconomic status across race. Compared to whites, blacks and Hispanics receive less income at the same levels of education, have less wealth at equivalent levels of income, have less purchasing power because of high cost of goods and services. So everything is in fact much worse for these populations, and it illustrates the non-equivalence of SES. The next slide emphasizes in 2001, a census report showed that whites had 10 times as much wealth as African Americans and Latinos, and during the economic downturn, blacks and Latinos their wealth levels have been much harder hit, so that today, whites have 20 times as much wealth as African Americans and 18 times as much wealth as Latinos. So even the worsening economic circumstances for groups is also striking. Next slide. Racism. There is a growing body of research that suggests that racism, through multiple mechanisms, has negative effects on health. I don't have time to talk about all the mechanisms. I want to give you some quick examples of just two of them. Research on the stress of discrimination, perceived discrimination as a source of psychosocial stress, and the evidence we now have, and touch briefly on segregation. Next slide. I need to do this for my students. They were teaching an undergraduate course this semester. My students were born long after the 1960s, think that discrimination was something that used to happen in the United States, that Martin Luther King's civil rights movement, discrimination is in the past. Next slide. Deva Pager is an example of one researcher who has provided striking evidence of the persistence of discrimination. The best evidence comes from audit studies. Audit studies is when you hold everything constant and vary only race. In employment, you would have individuals with identical resumes submit the application. The only thing that differed is the race of the person handing in the resume. The resumes are absolutely identical, and they look to see the outcome. She did a twist. She had one peer of black, whites, and Hispanic indicate on his resume he has served an 18-month prison sentence for cocaine possession. So you have African American with a clean record and one with a criminal conviction. What she found is what you would expect to find, that for any racial ethnic group, if you had a criminal conviction, you were less likely to get back a call back for a job. But she also found something we did not expect to find. It was easier for a white male with a criminal record to get a call back for a job than a black male or Hispanic male whose record was clean. The resumes were identical. And this is not 1964, this is 2004. She's replicated it in multiple cities. They find the same pattern. Striking evidence of the persistence of discrimination in contemporary society. Next slide. What does this mean? All the discrimination that minorities experience, they're not aware of. But to what extent does the stress of discrimination be one added burden that minorities carry? Next slide gives us an example of a review I did showing that discrimination affects physiological functioning at subclinical levels. It affects the incidence of disease. It affects health behaviors. It affects the patterns of access in medical care among minorities. And importantly, studies in the United States, in South Africa, in Australia, and in New Zealand showed that racial discrimination, perceived racial discrimination, makes an incremental contribution over and above income and education in explaining racial disparities in health. It's one piece of the picture of why we see these residual effects of race. Next slide. Just to illustrate, I developed years ago a scale to measure discrimination called the Everyday Discrimination Scale that doesn't even capture discrimination comprehensively, just looks at little chronic ongoing indignities that individuals experience. And I want to show you, next slide, the research of just one researcher, Tene Lewis, using the Everyday Discrimination Scale. And these are 8 different papers she's done where higher levels of everyday discrimination predicts a broad range of outcomes, including coronary artery calcification, C-reactive protein, elevated blood pressure risk, lower birth weight among pregnant women, cognitive impairment among the elderly, poorer sleep objectively and subjectively assessed, higher mortality among the elderly, and higher levels of visceral fat. So a broad range of outcomes all linked to discrimination. quickly, segregation, the next slide, is a driver of health outcomes in many powerful ways that we tend not to even think about. The next slide, segregation has declined, is the good news, but the decline reflects a few African Americans or Hispanics moving into predominantly white neighborhoods. The rigid structure of segregation, the concentration of urban poverty, and a high percentage black census tracts has not changed in recent decades. Next slide. What difference does that make? Well, let me go to a study done by David Cutler, economist at Harvard University. If you could eliminate in statistical models residential segregation, you would completely erase black-white differences in income, in education, and in unemployment. And you reduce black-white differences in single motherhoods by 2/3. That's how powerful segregation is as a driver of socioeconomic status and opportunity in American society. Next slide. The point I'm making is that segregation creates unhealthy communities. And there's a huge difference between healthy and unhealthy communities, and many poor Americans and increasingly Latino Americans, but for a long time, African Americans live in unhealthy communities because of the power of segregation. Next slide just gives some more examples. Let's go to the next slide. How strikingly different are these contexts? Two of America's most eminent sociologists, William Julius Wilson and Robert Sampson, said if you study 171 largest cities, there's not even one city where whites live under similar conditions than blacks. And the worst urban context in which whites reside is better than the average context of black communities, all driven by segregation. Next slide. We've got to move upstream. There's a lot we can do. There's a lot of growing evidence that suggests pathways forward quickly. Next slide. We need to do a number of structural interventions, and I want to give you just two examples quickly in passing. Next slide. The civil rights movement reduced the income gap, and if you look at the last 60 years, during the time of the reduction of the income gap between blacks and whites, mid-60s to late 70s, is the only time in the last 60 years when you had the health of African Americans improving more rapidly than the health of whites and a narrowing of the black-white gap in health, linked to improved economic conditions. Next slide. We have good data from the Monitoring the Future, high-quality scientific data from the Monitoring the Future study that simply by taking poor people and changing the neighborhood, no other intervention, health is improved short-term and even long-term, 10 to 15 years later, lower levels of obesity, severe obesity, lower levels of diabetes risk. All that was done was changing the neighborhood. Next slide. The Preschool project illustrates the power of investments in early childhood and its outcomes. Go through that slide quickly. I want to go to the next one. Just keep going. Just go to the next slide in the interest of time. There's a range of psychological interventions that have been shown, very simple psychological interventions, randomized controlled trials published in Science that shows we know how to eliminate the black-white gap in academic performance. Next slide. We can reduce the effects of disadvantage on racism. There are multiple things we have to do. Next slide. One of them is to develop a kind of care that addresses the social context. Because if we treat illness and simply send people back to live in the same conditions that made them sick in the first place, what in fact have we accomplished? There are examples, next slide, of things we can do. One is the medical legal partnership born in the Boston Medical Center, where a primary care provider in that context can refer the patient to a range of specialists. One of the specialists is an on-site attorney who addresses the social problems in the lives of parents and improves outcomes. A child with asthma in a moldy apartment will not breathe symptom-free regardless of all the medications the doctor provides if the living conditions are not fundamentally improved. Next slide. We also need to think of ways in which to empower patients, and we have a lot of evidence that we can empower patients. Next slide. There is dramatic evidence that if we empower communities, this is a study that I don't have time to discuss, but of First Nations communities in Canada, which have the highest rates of adolescent suicide in the world. And this study of almost 200 of these communities found there were some communities with no adolescent suicide. The group as a whole is doing badly, but some groups within that group are doing well. What predicts variation? They've created a measure of cultural empowerment and continuity, next slide, that captured the extent to which that tribe had self-determination and had some opportunities in their community where people could celebrate the history of their people and their culture. And they found that dose-response relationship, the more of these symbols of empowerment they had, the lower were the rates of adolescent suicide. Next slide. We also need to reduce cultural racism. I'm not going to elaborate on that. Next slide. One of the biggest challenges we have, and I'm going to wrap up now, I have 1 minute, is this point that we've talked about the need for political will. W.E.B. Du Bois wrote a book on the Philadelphia Negro in 1899, has a chapter on African American health in Philadelphia in 1899, and makes this striking statement in the chapter on health, where he says the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. One of the biggest challenges we face, we've talking about political will. How do we build political will? How do we create emotional connection on the part of the American public for the problem so there is sympathy and a willingness to act, in fact, so that we can move forward? Quickly, next slide. We need to build a science of interventions. These are some key things that I think we need to do. We need to rigorously evaluate interventions for their potential to improve health and reduce social inequalities in health. And this is maybe the most important point I'm making here today. If all we do is improve health, some of the most powerful strategies to improve health will widen disparities. We will only eliminate disparities if we can improve the health of the disadvantaged more rapidly than the rest of the population so that we ultimately narrow the gap. And we really need to think about how we do that. What's the optimal timing? What's the patterning? What's the sequencing? How do we create emotional engagement? How do we communicate about this? How do we put infrastructures in place to support this? There's a lot we need to do, but I think there's a growing body of evidence pointing us in promising directions to go and to make a difference to improve the health of all. Thank you very much.
Wow, David, thank you very much. Again, we're saving our comments and discussion until after our next presentation, and we'll have a break actually after our next presentation before we have the discussion period. I do just want to say at this point that we often, in the way we talk about population health or in Healthy People 2020, we talk about improving the mean and reducing disparities, and often we think that if we do one, we'll do the other. And in fact, as David just mentioned, that's not the case. And there are sort of evidence and resource trade-offs not yet fully examined and thought through in policy that we may have to come to grips with. Anyway, so now our final, so thank you, David, very much for those challenging words. So our final presentation, and then we will take a 15-minute break before we have the discussion period and time for public comments as well, will be Steve Wolf. Steve is a professor in the departments of family medicine, epidemiology, and community health at Virginia Commonwealth University. I mean, Steve has been enormously active as a scholar and a policy advocate in this field. He also has more than 100 articles, particularly on the social determinants of health, and actually his little education slider tool that he developed 2 or 3 years ago for the Robert Johnson Commission and other kinds of things. Most recently, he chaired the NRC IOM report on U.S. health in international perspective, shorter lives and poorer health, that has gotten so much attention. And in addition to the disparities within our country that we'll focus on, obviously the international perspective provides us some lens to look at that. And so I'm really glad Steve could come and wrap up this session of presentations, and then we'll take a break, and then we'll have time for questions and discussion.